Yes, good morning, everyone.
Maybe this starts out for now. Here. Now, this is one of the key ideas from Labour, and I think it's one that we do have to challenge. And the argument is that the private sector has spare capacity, why not use that to get rating this down? And Wes speaking in his own inimitable way said anyone who opposed that or was just doing it on the basis of ideology because, and this is how people categorise everyone in this room. You're middle class benefits because you oppose this, and actually you go and use private care yourself, but you don't want the working class to be able to access it. And this, of course, is an unevidence-based opinion, and actually the whole policy is unevidence-based. Next slide, please. So one of the interesting things about the private sector is it is a bit of a black hole in terms of information. And if you're going to have a policy for the NHS which involves the private sector, you really should have a lot of information at your fingertips. But this is just one private provider's website that I found very quickly, looking up, trying to look up details. And the first thing it says, actually there's a slide before that, if you could go that one, Lucy. Yes, the private sector, that's fine. So the private sector, remember, we're normally told is agile, lean, efficient compared to the NHS. Now we're being told something different, that it actually has lots of people sitting, twiddling their thumbs, unused equipment, unused theatres. That doesn't really add up to me. It's quite small around compared to the 120,000 in the NHS. And if you try and find out information about the private sector and its activity, it's quite difficult. So this, for example, is a website devoted to private health. The first thing it says is facts and figures about the private health sector in the UK are surprisingly hard to come by because there's no central authority or organisation responsible for collecting and collating data from many private hospitals. And this is absolutely the opposite in the NHS, where all hospitals report lots of data in detail. Next slide, please. And this was highlighted also in the British Medical Journal article very recently, which again emphasised there's a lack of information on the private sector workforce, on hospital capacity and outpatient services and prices. So it's actually quite difficult to determine the implications of boosting work in the private sector of the NHS when you have this dearth of information. So that's one point. It's very difficult to come up with a rational evidence-based policy. Next slide. Now, is the private sector there to help the NHS? I mean, recent experience suggests that in terms of the contracts, the NHS is run rings around by the private sector. And these are a few which you'll be very familiar with. 37 billion on test and trace. What was the final conclusion about that? That it didn't actually prevent the spread of an infection. The PPE scandal, 13.6 billion spent, 9.9 billion written off. Hospital contract first year of COVID. Hospitals paid to do NHS, help the NHS. We don't know how much it costs. There's a suggestion it was 2 billion, but it may well have been twice that amount. And commercial confidentiality, we don't have all the details. But what did they do? Well, 39% of the days, there wasn't a single COVID patient in those private hospitals. And actually, they took the opportunity to do more private work, and the amount of funded elective care they did from the NHS actually nearly halved. So this is how the private sector helps the NHS. And immediately after that, you had a contract of 10 billion, 2.5 billion each year for 4 years to the private sector. And essentially, the private sector was kept afloat by money being given to them without any benefit to the NHS. Next slide, please. Our key argument is that there is only one pool of staff, and this is critical because the private sector does not train staff, it's staff from the NHS. When it comes to consultants, they are working in the NHS, and then in their job plans, they will contract to spend some time in the private sector. So if I had surgical colleagues in my hospital who wanted to do private work, they would say to the managers, I'm not going to work for the NHS on Friday because I will be doing private session. And if the managers agreed to that, which normally is, then they weren't there on Friday, and they were in the private hospital. And what we actually have seen, for example, with hip replacements, that as there was a shift to more hip replacements in the private sector, the numbers of hip replacements in the NHS actually went down. So this idea that there is spare capacity that you can have on is not borne out in reality. Also take, of course, non-medical staff from NHS units to staff in the private sector, and that's further undermines NHS services. Going to the private sector exposes patients to greater risk in some respects. I mean, this is why they cherry-pick low-risk patients appropriately enough. Most of the hospitals are very small, average about 42 beds. They don't have a multidisciplinary care team. They don't have ICU, it's highlighted in the Panorama programme recently. And they have very poor medical cover at night if things go wrong. And we've seen scandals like the breast surgery scandal, which really challenges the whole model of how the private sector works in terms of its governance. The fact that consultants work freelance in the private sector, they're not employed directly, and this means the private sector can absolve itself from responsibility. And the private sector actually uses the NHS as a backstop. If things go wrong, back to the NHS. Nearly 7,000 patients a year transferred from the private hospital back to an NHS hospital. If there's negligence by a surgeon working in the private sector, that surgeon is employed by the NHS picks up the bill, this kind of thing. We saw with Centene and the general practices in London how they were heavily using physicians as agents rather than GPs. So there are certain risks which need to be acknowledged if you're going to have this policy about using the private sector. And always we need to bear in mind that the private sector is about making profit. I mean, that's what it is there for. They are profit maximisers. They're not cost minimisers. They are not actually there to help the NHS. Next slide. So what does spare capacity actually mean? What I would suggest is spare capacity means if you give us the money, we will develop the capacity. But only if it's on our terms and it's favourable to us. And we're not interested in complex stuff. We're interested in high-value, low-risk surgery. It's easy for us to set up treatment centres for things like cataracts. I'm very happy to do that, but we don't have to do anything else. So with ophthalmology as an example, cataract surgery is the most common operation done in the NHS. And the NHS now sends the majority of cataract patients to the private sector and pays the private sector to do them. In the last 5 years, 126 cataract clinics for surgery have opened. No risk. They don't take complex patients. They won't take the obese diabetic with cataract, for example. That would take longer to do and mean that they got through less patients. This takes senior consultants, ophthalmologists away from the NHS eye units. They're then not part of the team. They're not training. It also, if you think about it this way, cataract surgery is the bread and butter for trainee doctors. So surgeons who are training to be consultant ophthalmologists, a lot of their experience comes from doing cataracts. Now, most of those cataracts are in the private sector, and the trainee surgeons, anyone in the sub-consultant grade, are not getting those patients to operate on. And what we've seen is that the private sector has dropped the threshold for operating on cataracts. So if you have an eye examination of a very early cataract, it's not bothering you. No, they say, you can have an operation, we'll get your cataract sorted out. What that meant is that the number of cataract operations has gone up. The proportion of the budget for ophthalmology on cataract surgery has gone up. That means there's less money for everything else. What is everything else? It's complex eye conditions, including eye conditions that are going to make you blind, and that's left to the NHS, which has less staff, less money, more complicated patients to look after. And this is how, again, this turning to the private sector actually undermines the NHS and is actually a threat to patients in some respects. Next slide, please, Lucy. So what is the opinion about the private sector? Well, there's lots of health think tanks. They don't like it. They point out, amongst other things, it will increase inequity. This is because private facilities are generally in the London area and the southwest. They're not evenly distributed, and they're not located in poor areas. They say that it's not a substitute for addressing the NHS's problems, that it makes it harder for the NHS to expand care, that the private sector can't deal with complex. And they say, look, what worked in the past to get waiting lists down? What worked in the past was increasing funding and increasing staffing. Listen to the experts is one message for West Streeting. Next slide. And we've been here before, remember. So under the Blair Brown government, we had independent sector treatment centres, private sector coming in, would reduce the waiting list, it would all be wonderful. And what actually happened? They added very little additional capacity, they cost more, and they undermined NHS services. So far from preventing a two-tiered NHS, which is what he wants to do, relying on spare capacity, entrenches two tiers, money should be spent on developing NHS services, diverting money in simple cases from the NHS to the private sector fosters the NHS's dependence long-term on the private sector, and the NHS is left with higher costs. And this is my last slide, if Louise is getting anxious. So, last slide, next one, please, Lucy. So, next slide, should be one more. So this is just my concluding statements. Any procedures carried out in the private sector actually have the capacity to reduce what the NHS can do. Anyone can bring down waiting lists by ignoring all the difficult and serious stuff and focusing on the easy things. But switching resources to the private sector, focusing on the easy stuff, actually risks harming the most vulnerable patients. None of this is acknowledged by West Streeting. And the rational policy is actually to invest in the NHS, build the lower cost NHS capacity for the long term, not investing in high cost private capacity. So it's really an outrageous policy that has no evidence base, and it's very, very challenging for us, I think, to oppose what in some ways seems like a sensible idea, but in reality is simply undermining the NHS and entrenching a two-tier system, investing in the private sector. This is not the right thing to do. Thank you.